Hi, my name is Luis Paladines and I'm going to talk about Caplacizumab for acquired thrombotic thrombocytopenic purpura. First, definition. Acquired thrombotic thrombocytopenic purpura is a potentially life-threatening thrombotic microangiopathy resulting from systematic microvascular thrombosis and leading to profound thrombocytopenia, hemolytic anemia, and organ failure of varying severity.
Acquired thrombotic thrombocytopenic purpura, or ATTP, is a rare, life-threatening autoimmune blood clotting disorder. During the normal blood clotting process, the plasma protein von Willebrand factor is important in recruiting blood clotting cells, also called platelets, to damaged vessels to seal the injury and stop the bleeding. In healthy individuals, von Willebrand factor is immediately cut up into smaller pieces by an enzyme called ADAMTS13 to prevent spontaneous recruitment of platelets when blood vessels are not damaged. However, in ATTP patients, antibodies that block ADAMTS13 from working properly are present. This results in an accumulation of ultra-large von Willebrand factor molecules which will bind to blood platelets and cause excessive formation of blood clots. The formation of these blood clots in small blood vessels throughout the body leads to a severe reduction in platelets, also called thrombocytopenia, a further breakdown of red blood cells referred to as hemolytic anemia, and an insufficient blood supply to tissue, also known as tissue ischemia. This results in organ dysfunction, commonly involving the brain, heart, and kidneys, and may cause acute thromboembolic events such as stroke and heart attack. Despite the current standard of care, ATTP patients remain at risk for significant morbidity and mortality.
Applications in medicine. Treatment of acquired TTP consists of rapid initiation of plasma exchange to remove autoantibodies and ultra-large von Willebrand factor, multimers, and to replace ADAMTA13. Immunosuppressive therapy inhibits autoantibody formation, although the survival rate among patients with acquired TTP exceeds 80%. Pros and cons. The introduction of Caplacizumab, which can quite begin blocking von Willebrand factor and platelet interaction after intravenous injection, has the theoretical potential to reduce microthrombus formation while allowing time for plaques to begin rising. Adam TS 13 activity. A significantly higher risk of severe bleeding in patients treated with caplacizumab is a substantial concern, especially in settings of no proven mortality or major thrombolytic event.
TTP is an acute, life-threatening disorder that affects primarily young people and primarily females, but it can occur at any age in young children, usually adolescents, up to 70, 80 years old. It's a devastating disorder that presents very acutely. Patients won't know that they have the condition, and the symptoms can be very non-specific at initial presentation. The problem is that the longer the diagnosis is left before treatment started, the condition usually deteriorates, and about 10% at least of patients end up intubated in the intensive care unit. Furthermore, other symptoms that affect patients acutely are usually neurological symptoms, such as strokes, epileptic fits, or they can have cardiac involvement, and they usually don't know about the cardiac involvement because there's no symptoms associated with.
Issues applied in Ecuador. Despite great improvement in outcomes with the use of plasma exchange, the morbidity among patients with acquired TTP remains 10 to 20%. Conclusion: treatment of acquired TTP with plasma exchange and immunosuppressive therapy takes time to achieve resolution of the disease, and even when the patient have a response to therapy, they are at risk of future microvascular thrombosis, which is unpredictable in its onset, severity, and outcome. Caplacizumab, through rapid blocking of von Willebrand factor-mediated platelet aggregation, prevents future platelet aggregation more rapidly than conventional treatment alone, which could potentially prevent short and long-term end organ injury due to ischemia.
TTP is a specific form of thrombotic microangiopathy, which was historically systematically fatal, because this disease leads to the formation of microthrombi in most organs, and without adapted treatment, patients die of the disease. Historically, we started to treat those patients with a daily plasma exchange until complete remission and with steroids. This regimen allowed to significantly improve the prognosis of the disease, since the survival rate translated from almost no survival to more than 85% of survival. So this was a great improvement. But patients needed to be treated for a long time with plasma exchange, with a lot of complications from this treatment. So in this context, other treatments were added to these standard treatments. And these treatments include rituximab, a B-cell depleting agent, which is able to limit the duration of daily plasma exchange. So this was a great improvement, since the duration of this heavy treatment with plasma exchange was limited, and rituximab allowed to prevent 1 year relapses. So now it is gaining popularity, and it is used more and more at the acute phase of the disease, and even frontline in all patients. The third step of the management of TTP is very recent, with the development of a nanobody directed to von Willebrand factor. And this nanobody, called the Caplacizumab, is able to still decrease the duration of treatment with plasma exchange. So the three axes of treatment of TTP, daily plasma exchange and steroids, rituximab and caplacizumab, is completely transforming the prognosis of the disease. And now, with the two randomized control studies run to evaluate caplacizumab, it was reported that actually no death was observed. No refractoriness was observed either. And we could observe that the duration of daily plasma exchange was significantly reduced as compared with the historic regimens.